Hello, everybody, and welcome to, I think, what's going to be the first edition of the Musings Show for 2024. We are about 6 days into it. I'm recording this. This is Egbem B1 Monjimbo, and I'm coming to you on Vosa World Radio and eventually on the Vosa World TV channel on YouTube. And I have a guest who is on for the second time. He's been here before. We had a long chat about a lot of stuff. He's back again. And I'm going to just ask him, for the benefit of those who were not here the first time, to go ahead and introduce himself again, if he does not mind.
Hi, Egbert, thank you for having me today, and it's an honor and a privilege to be your first guest for the year 2024. I think this comes with good tidings. I am Dr. ATOGHO, and I am an obstetrician and gynecologist in Miami, Florida.
And if that is the professional side of you, want to cover the social side of you?
Well, the social side of me is I'm Cameroonian by birth, as you know. I was born and raised in Cameroon, grew up in Yaoundé, went to École Bilingue, where your mother was my principal, my headmistress, let me put it that way.
That's how it was called, yes.
And I went to Collège Bilingue and then Casban Bili. Spent some time in Guayaquil in Nigeria at Ahmadu Bello University, and then I came to the United States in the mid-90s, where I graduated from Howard University and then did my medical school at Howard University and my specialization at Drexel University, Hahnemann Hospital in Philadelphia. I've been in Miami for the last 13 years, and God has been good to me. That's all I can say.
He has. I can confirm that. I can confirm he has been good to you. That side of you, that's the academic stuff you've covered. Professionally, socially, good to go. But I wanted you to say that part so people know I'm not talking to a quack. I didn't just go pick anybody off the street. I could have done that myself, opened some book and just read Google. But I wanted him here because he does know what he's talking about, has been practicing. For how long? Because I think you practiced even before you got to Miami.
Well, I did my specialization in internal medicine for a year at Howard University, and then 4 years of obstetrics and gynecology in Philadelphia, and then came to Miami.
He's been there a while. And if you listen to the last show, we talked about a wide range of things. Okay, so we're talking about the kinds of things that affect women, women's issues, kind of conditions that affect women. But today we want to narrow it down to uterine cancer. I know why I'm doing this. I'm sure that's the pin right there. It's that will tell you why. That's a very close, dear sister friend of mine that passed away tail end of last year, and that is what she passed away from. And I wanted, in honor and memory of her, to go ahead and have us shed some light on this condition, so more people are aware of it than probably are, and so save lives. You never know. You just never know. So if you wanted to define uterine cancer, because I hear uterine, I hear endometrial, I'm not even sure which is which. If we want to define it, what is it?
Yeah, and since we are talking in honor of Sister Marie, who's been a dear elder sister to me and a classmate of my elder sister Barbara at the Second Baptist College, and obviously close to you, and a sister to my friends Emmanuel, Bob, Jerome. I think that it's important that her death should mean something to us. And if there's something we can do to give back to our communities, if there's something we can do to educate somebody else, if there's something we can do to save another life, then yes, then we should do it at least in our honor. Now,
Exactly.
with regards to uterine cancer, I think that it is important that first of all, we should have a good idea of the female anatomy, okay? Because it is not uncommon that many people will say, oh, somebody died of uterine cancer, and we are not exactly sure, because it could have been ovarian cancer, it could have been cervical cancer, it could have been vaginal cancer or vulvar cancer. And then sometimes for the person who is not specialized in this field, anything that happens down there has to be the uterus. So
Right.
just for purposes of our own education, and so that we have a broad idea of what goes on. There is, first of all, the vulva, which is what we see from the outside.
Mhm.
And there's the vagina. And then there's the cervix, which is the entrance into the uterus. And then we have the uterus, and then we have the fallopian tubes, and then the ovaries. Those are the things that we need to touch upon if we want to understand the female anatomy and the different gynecologic pathologies that could exist. So vulvar cancer is usually seen on the outside, is easily visible to the eye, and some of the symptoms would include bruising, itching, and it is usually takes a long time before you realize, okay, this thing is not normal. The color is not right. I'm always itching, and there's always blood every so often. And it is easy to diagnose. It's easy, you diagnose in the office with a punch biopsy, for example, or sometimes just by observation. But in order to have something definitive, you need to do a biopsy. Vaginal cancer is not very common, but it also presents itself in virtually the same way: itching, burning, bleeding, and can easily be diagnosed through exam in the office, biopsy once more, and then you have a pathology. Cervical cancer is the one that we all hear about and we know about most of the time. One of the primary ways of diagnosing it is doing the pap smear. Okay, so there are very different recommendations about how often we should do a pap smear. But the long and short of it is that a cervical cancer is screened with a pap smear and diagnosed with a biopsy that follows a pap smear that was abnormal. And one of the symptoms is vaginal bleeding. Postcoital bleeding as well is something that you should be aware of. And one of the main causes of cervical cancer, and also a cause of vaginal cancer and vulvar cancer, is the human papillomavirus, HPV. So that's something that we should know about, and we should also understand that there are vaccines that are given to prevent cervical cancer. We're taking what you call a HPV vaccine.
Okay, let me just jump right in there. And so, who should take that vaccine? Let us just so that we can talk directly right now. Who should take
There's an age range between, I think, 10 and 29 is the
Okay,
ideal time to take the vaccine, and it's a 3-course vaccine that you take. And
and so that
you can get it,
3 course thing means
you can get it through your primary care doctor. It doesn't have to be a gynecologist.
Oh, okay,
Yeah.
that's good to know. And then, so you're saying okay,
3 course, you take one, and then I think 3 months later you take another one, and then 3 months later you take another one, something like that.
and then you're done for life.
Yeah, you're done for life, yes. You're done
Okay, because it's not like you see you're used to dealing with children and everything. Booster dose.
No, no, you're done for life after that.
You're for life after that. Okay, then let's please just make the appeal. I'm jumping in there to say, okay, just go get the thing. I don't know that
It confers a significant amount of defense to the person who has the vaccine. It doesn't mean that you're never going to have HPV, but the HPV is not going to affect you as badly as a person who never had the vaccine.
You know that I wonder why this is not being pushed as much as any other thing. The way we have the fatal cases down the road, I'm wondering why you don't hear about it as much as you hear about maybe even the COVID vaccine, because it's not a pandemic kind of a thing, it's just part of what is going on. I don't know that I have heard that many doctors really recommend it, especially because you don't need to go see the gynecologist for it. You can get it through. What is going on? Why not?
As a matter of fact, I think you can even get it at the pediatrician's office because children of pediatric age are already eligible to have the vaccine.
Wow. I probably am the one just showing my ignorance, but I'm a woman and I talk to other women. I don't hear people saying, "Oh, I just got my HPV vaccine the other day."
Yeah,
I hear about all kinds of things, but
yeah,
not that.
it's something that we should pay attention to and that we can do.
Please,
Yeah.
please.
And then now after going through the cervix, you
Mhm.
go into the uterus. And the uterus is basically divided into 2 parts. There are 2 kinds of cancers you can have in the uterus. You can either have the cancer of the lining of the uterus, which is called endometrial cancer, or you can have the cancer of the muscular aspects of the uterus, which are referred to as sarcomas.
Okay.
Those are a little bit more difficult to diagnose. The endometrial cancers are usually diagnosed in patients who are postmenopausal or patients who have been exposed to a significant amount of estrogen during their lifetime, patients who are morbidly obese, patients who have been taking things like tamoxifen for breast cancer. So an extended exposure to estrogen would predispose you to endometrial cancer. And it presents also as abnormal bleeding. And it can be diagnosed primarily by doing an endometrial biopsy in the office. And if you're not particularly pleased or confident in the result that you get from the screening, which is the endometrial biopsy, then you can do a dilation and a curettage in the operating room where you get a sample from the endometrium and send it for pathology. The other kind of uterine cancer called the sarcoma is more difficult to diagnose. It's more difficult to diagnose because it is found inside the muscular aspect of the uterus. So when you do an endometrial biopsy, you never get to the muscle. You only get to the endometrium. So some people, and I have to say this right, some people who have fibroids, for example, it's only when they remove those fibroids that they realize, oh, by the way, there's also a sarcoma. And I'm saying this because having a fibroid does not predispose you to having a sarcoma. So fibroids never develop into sarcomas.
Right.
It so happens that is more often the person who has a fibroid and then went and had a hysterectomy who happens to find out, oh, by the way, they found cancer when they removed the fibroid. You see, so
I can quite relate, because that's what I'm just listening, I'm nodding and saying that is what you went for a check. Mine was called a hysteroscopy. I think that's what they called the thing.
yeah.
And this bleeding thing, I've been listening to you, every single one of the things you've been talking about. One of the symptoms is this abnormal bleeding.
Yeah.
You're past and you said menopausal. What are you doing with this bleeding past this time? And
Right.
then you go check, and then they said, I think we're going to send you to go get this thing checked. And I heard the C word and I went, hey, Jesus.
Yeah.
Just like the fact that they're sending you to a thing, because he said, I can't do this here in my office. You're going to have to go see an oncologist. I heard
Oncologist.
that, and I was like, whoa. But that is not that, I mean, I knew you're saying you know what you're talking about, but I'm just nodding and saying, bingo, that is what was the issue, the fibroid thing. Then it came on back and they said, go take a check, go get this thing checked.
Yeah. So it so happens that it's the sarcoma part is the one that is more difficult to diagnose, especially, and usually
And isn't it the most serious one too?
Depending on when you diagnose it or when you get to it. If it's still contained, then that's fine. If it's kind of deep into the muscle and it's spreading a little bit, then it can be devastating. Yeah.
Yeah, not God, so it's not you I can ask. I just don't understand the wickedness. I'm sorry to use a layman's term, the wickedness of some of these things. Like you just really don't want to be found. So if I don't have this thing and I don't go for this, for this, so that they can catch it, then I don't know. And then whenever they catch it, I'm lucky, blessed or not, if they find out that it's a different stage. Sorry, I am sounding exasperated because I am coming down the road. I'm like, what is this?
That's
But it's
understandable.
I just have to let it out of my system. I really did, because
Yeah.
I'm sequasa.
No.
Really.
So
So you named that this one, the sarcoma one, that is harder to find.
yes.
Because at the uterus, is there another kind?
No, for the uterus, it's just the endometrial and the sarcoma that you're really concerned with. Then ovarian cancer. And ovarian cancer, it's also one of the most common causes of death of the female. I think after lung cancer and cervical cancer, then you have ovarian cancer. Ovarian cancer, it could originate from the germ cells of the ovary or from the epithelial cells. That's unnecessary details, but there are different kinds of ovarian cancers that you can have. The sad thing about ovarian cancer, once more, is that there's no screening test for ovarian cancer. We only find out when we have it. You know,
Weekends because this whole thing.
unless for some crazy reason, say you had an appendectomy and the doctor decided to look down at your ovaries, I'm like, man, this doesn't look right. In general, you know about ovarian cancer only when you already have it. Or it could be an incidental finding on an ultrasound where they say your ovaries are unnecessarily large and then you need to do something. You need to follow up and see what's going on there. But other than the fact that people have symptoms such as early satiety, maybe they put on weight or they lose too much weight or they have fluid in their abdomen, loss of appetite, things like that. There's no tests. There are no tests. There are no common tests that we can use to diagnose ovarian cancer. But for purposes of education, maybe we should also know that a good history, a good family history can help in the sense that if there's some ovarian cancers that are hereditary, and so if you could say, for example, you had a sister or a mother who had breast cancer at the age of 35 or 30 or 40, then you're like, okay, maybe in our family there's something going on because there's a relationship between some breast cancers and ovarian cancers. So you do things like the BRCA test that could tell you, oh, by the way, you're at increased risk for ovarian cancer, and then they can start looking into it at an earlier age.
Okay, that looking into it, since you cannot quite diagnose the thing, what do you do? You're looking into it. Okay, here I am, the predisposed person.
Yeah, so
And
the BRCA test will tell you if you're at risk or not. It's a blood test.
Okay.
So they don't do it for everybody.
Okay,
They
yes.
don't do
So
it for everybody.
I've gone and I am at risk. Then I
Yeah.
do.
Okay, if you're at risk, then you can do a prophylactic ovarectomy, which is they remove the ovaries. Just like for people who are at risk for breast cancer and they remove the breasts, you can do a prophylactic ovarectomy. Well, the downside is that they put you into menopause early, but hey.
But you live longer. You see,
You know.
it's like, and you said you're originally from Cameroon, so am I. And look, for me, the ma who was told this, even then the doctor was still very grave about it, saying, you see, trying to according to him, break the news to me, that kind of way. And I'm going, hey, 59, what am I doing with all of that stuff? But I can imagine you're telling a 20-something-year-old who is not married yet, has no children, that is not an easy decision to take at all.
The good thing is that for the younger people who have this kind of problem, what we usually counsel them to do is to go ahead and have their kids early so that after they have the kids, then you can do
Take everything away.
Yeah.
But that would be if they don't have the actual diagnosis yet, right?
That's
They're
correct.
just predisposed.
That's correct.
I'm talking about if you have the diagnosis, you're like, okay, you just told me that I actually have cancer stage something. Let me run, go have the children and come on back. That's what I mean by it's not an easy thing.
It's not an easy discussion to have, by no means.
Not at all. Not at all.
The good news is that it doesn't happen very often at that very young age, but it's not an easy discussion to have at all.
No, it's not like, okay, choose this one. You just say, hey, just sit down there and say, okay, fine, I'll just go for it, right? Sitting there in the doctor's office, you really need to go home, sit down and think it over, cry it over, pray it over before you come on back to say anything. Yeah. And so now let me go to a question, which, as I said, for someone like me, in my case, the doctor said, okay, now take the uterus out, take the so and so. And of course, then they start telling you the statistics and say, actually, what I was clinically told is that the chances that you'll be back here again to take some other of one of those things you've called out again down the road makes you, it'll better if you consider taking everything out. So I'm saying, is that some recommendation that you give most people? Because what I was sent there for wasn't to go take everything out.
Yeah, the thing is this, the recommendations have changed over the last 20 years. Okay. So when I started residency, I think the recommendation was that if you're going to do a hysterectomy, which is if you're going to remove someone's uterus for whatever reason, say she has fibroids, she has pelvic pain, or she has adhesions, if you decide to take the uterus, go ahead and take the uterus, the fallopian tubes, and the ovaries. For anybody who is over 50, yes, you just take it out. Then over the next 10 years, they were like, okay, if you're going to take out the uterus, just take out the uterus, because even if someone goes into menopause, the ovary is still producing a small amount of estrogen that helps them. So we shouldn't take out the ovaries. And then fast forward again, then they said, you know what, even if you don't take out the ovaries, take out the fallopian tubes as well, because it's been shown that the fallopian tubes also predispose people to ovarian cancer. So some of the ovarian cancer comes from the fallopian tubes. So now the recommendation is, if I'm going to take out someone's uterus for whatever reason, I should take out the uterus and the fallopian tubes. I should leave the ovaries, especially for someone who doesn't have any predisposition, because it confers a certain amount of protection with regards to menopause, bone growth, bone strength, and all the symptoms that accompany menopause. So someone would have to be probably in their mid 60s or late 60s for me to say, okay, I'll take out everything, you know. So yeah, you're always worried, but that's what the recommendation is.
Yes, and that they went through that whole thing with me to explain. And for me, the choice was like this. They started trying to tell me, go think it over. I'm like, I think it over. I don't need to. Well, show me where do I sign? Take
Yeah,
everything away. For me, it's a logical thing. How am I going to come back here and you tell me that another part is affected? But as I'm
yeah.
saying, easier
You just
done, because the youngest child that I have here is 30.
yeah,
What's the follow back coming from? What am I doing? I'm sitting here waiting for grandchildren instead. But I
yeah.
can imagine somebody else in that position, they wouldn't be as quick to say, to
Take
make
it
that
out.
decision.
Yeah.
Not at all.
So
And so,
go
what
ahead.
are let us talk survival chances of each of these things? I'm trying to see on the scale of all of the, because all of the cancers are, hey, they eventually have the potential of you passing away from one or all of those things.
Yeah.
But I'm thinking on this, for this uterine cancer thing, where does it fall in the spectrum of things, and what are your chances once you're diagnosed? I guess maybe it's the severity, the stage at which it is, that determines it, or what?
It's the stage at which you are when you're diagnosed that determines everything. If you diagnose somebody who has, well, it's the stage at which you are, and it's the kind of uterine cancer that you have. So we talked about the sarcoma and we talked about the endometrial cancer.
Mhm.
You go to endometrial cancer, there are like 4 different kinds of endometrial cancers.
Okay.
Endometrioid cancer, adenocarcinoma, everything. So the most devastating is the endometrial cancer. So that diagnosis is not a good one. And then now, depending on how aggressive that cancer is, you also have to look at what stage you are in, that is how much penetration into the uterus, and if it has gone outside of the uterus. So if you have say uterine, you have endometrial cancer, which is adenocarcinoma, it is not as bad as if you had endometrial cancer that was endometrioid in fashion. So it's not going to be as aggressive.
Mhm.
So it's usually the oncologist that has a good idea of survival, but
Right.
usually it comes with cancer, it's usually 5 to 10 years. But depending on the one that you have, I've seen people who had endometrial cancer or ovarian cancer who lasted 20 years. 20 years.
And in that 20 years, other people passed away from other things that were not.
From other things. There are many people have gone who you're like, this man is still here, this person is still here, you know. One thing we used to talk about when we were in residency is that there's going to be a patient that you took care of when you're in first year who will die when you're in fourth year. There's always going to be one. So
Right.
when you go through your oncology rotation and you're meeting people, you're wondering who is the person who is going to pass when I'm chief resident.
Just like that song, the hymn, the chorus that they sing in the funeral, and think, who will be the next?
Who'll be the next? Yes.
Who will be the next? Well, it is a sad, just puzzling situation, and I keep going back to this vaccine thing. I know because they cannot. Other vaccines are mandatory, right? You know how it was. Well, mandatory. If you don't take it, you don't take it. You have your own beliefs. COVID came. They actually said you can't travel if you don't have the vaccine. You can't do so and so thing. Should there be? I don't know. Should it be pushed? I know you cannot force anybody to do anything.
You can't
Shouldn't
force
there be a more? Yes.
the thing is, it's not an epidemic. It's not a pandemic, and so the potential for it to be devastating the people around you is not there, so they can't really mandate it.
Cannot mandate it.
For example, I had to go take the flu vaccine the other day. I had to take it because if I don't take the flu vaccine, I can't work. I
Right.
can't go to the hospital, and it's a problem. So I had to go take it. But
Maybe I should ask what the side effects of this HPV thing is. That where it is? Is that because the side effects too can then limit or mar or bar something, reduce
no,
something?
no. You have to understand that HPV is a sexually transmitted.
Right.
70% of women of reproductive age have HPV. I'll say it again. 70% of women of reproductive age have HPV. And going back to your point on the vaccine, I think the reason why it would not be made mandatory is because you also have the opportunity of doing pap smears, which is a screening test for the effects of HPV.
Okay.
HPV is the cause of cervical cancer. Yeah, HPV is the cause of cervical cancer. So if you do your pap smears regularly, there's a good chance that if you were to develop cervical cancer, they would find out way before it ever gets to anywhere important. So if you have an abnormal pap smear, there are other tests that you can do. There's a way of monitoring you, and then if it starts moving towards cancer, they can do some surgeries to take off those abnormal cells, and so it can prevent cancer. So in general, maybe only 1% of people who are compliant with their cervical cancer screening will ever develop cervical cancer. You see, so that's why when we are talking about gynecologic cancers, cervical cancer is not considered hereditary. Ovarian cancer is considered hereditary because if your mother had it, your sister had it, there's a chance you could have it. Cervical cancer is sexually transmitted.
Exactly.
For lack of a better word, cervical cancer is as a result of sex. It has nothing to do with hereditary or anything.
Right.
Yeah.
But I'm sitting here and going, okay, go keep doing the screening so you can find out if you have it down the road, get a vaccine and not have it at all. I am looking at the thing and whether it's my Bisonga bank sense that is not working.
You get the vaccine. You get the vaccine to protect you.
Yes.
You're still going to have it. You can have HPV, but the HPV will not affect you as bad as a person who didn't have it.
You see, I suck at arithmetic. I did. So I don't know why it's not
the concept of a vaccine is this. The concept of a vaccine is to provide a defense mechanism. Okay. The human body has a natural defense force. It has a natural defense force. And look at it this way. The army, the Navy, the Air Force, they simulate the fight, they simulate the war all the time. That is your natural defense.
Correct.
What a vaccine does to you is that the vaccine comes and simulates the war. So your body fights that war. So that when the real war comes, the body is prepared to fight. So the vaccine is just a small war, a small attack, and to see how your body is going to react to it. So now when the real attack comes, your body is like, I've seen this thing before, I'm going to crush it. Right. So the vaccine doesn't prevent the war. The vaccine prepares you for war.
Don't you want to be prepared just in case, since I don't know.
That's why you take the HPV vaccine. You take the HPV vaccine.
And that's what I'm saying.
Yes.
That's what I'm saying. we push it, take it. I mean, I am saying I just managed to.
I encourage people to take it. I encourage people to take it.
I just live my life without that awareness of
Yeah.
it.
Yeah.
And that's why for me, that's really important. And that's really why I wanted you here to come and just tell us what it is that we can do. That we know there are many things that are out of our hands.
Yeah.
But you do the best you can do from your own part to prevent the things. You mentioned a whole bunch of them. You said obesity is you're predisposed. Is there anything tied also to race? Meaning, you know how we can most of the time we are more predisposed, or in this case, no.
In this case, no. In this case, no. It's mostly physiologic. Physiologic, which is exposure to estrogen.
Okay.
Whatever reason, exposure.
As a woman, how are you not exposed to estrogen?
Okay, so you have a certain amount of estrogen that you produce, and for lack of a better term, your body gets rid of it. But for someone who is obese, the estrogen is not gotten rid of as easily because the estrogen sits in the adipose tissue, the fat tissue. So their level of estrogen is higher than the average person. And because of that higher level of estrogen, it works on the lining of the uterus and causes endometrial cancer.
Okay.
So some of the things that we need to look at is one, what are the causes of these cancers and how can we prevent them?
That is
and then what are the things that should trigger me to say, hey, let me get this thing looked at. So the first thing is the bleeding. Okay, you should know yourself. What is my bleeding pattern? I bleed every month. I bleed for 5 days. I bleed for 10 days. I bleed for 15 days. Is this normal? It is okay to bleed for 4 to 6 days. You fill up maybe, I don't know, 4 pads, 5 pads. The moment you start telling me that you're filling up 10 pads, you're soaking 10 pads, you can't sit in the living room for a long time. You have to run to the bathroom to change your pads because you're going to soil your sheets, soil your furniture. It's a problem. It could be a fibroid, it could be a polyp, it could be anything. Get somebody to look at it. Get somebody to look at it because it's not normal. If your bleeding pattern makes you uncomfortable, you can't leave the house when you have your period. You're in so much pain. You can't go to work. You have to call out of work. You've had blood transfusion several times. You need to have somebody look at it to find out why. If you're having too much pain, you need to find out why you're having that much pain,
Not just take Tylenol or Midol and suppress it.
No.
What you're doing is not getting rid of the thing.
Get an ultrasound so that we can know why you're bleeding that much or why you're in that much pain. If you're bleeding after sex, you have to find out why. It's not normal for you to bleed after sex or during sex. It's not normal. If you're bleeding between your periods, you need to find out why. It's a problem. You can't do that. If you're bleeding for 1 month at a time, even if it's not too much blood, you need to find out why. So that's the first thing. You need to be curious. You need to be attentive. You need to be proactive.
Definitely.
That's the first thing. And then we need to do our pap smears regularly. It's good to develop a relationship with your doctor so that they know you. Don't go from one doctor to the next, jumping all over the place, because then
they don't know your history.
Information gets lost. Exactly. So get your doctor, trust your doctor, talk to the doctor, have a relationship with that doctor.
Oh, yes.
Do your own self-breast exams at home to prevent breast cancer. Do your own self-breast exams. Do your mammograms on a regular basis. Okay. Watch your weight, because that alone is a problem going down the line for endometrial cancer. HPV vaccine, if you're at that age when you can, do it for your girls as well. Ovarian cancer, breast cancer, know your family history, your sisters, your uncle, your aunties, who died from what, when, how old were they when they were diagnosed, all of that stuff. And then you can go ahead and tell your doctor, oh, by the way, I have a cousin who died at the age of 45 from breast cancer. I'm worried. And they'll
Right,
say, you know what, maybe we should do the BRCA tests for you. And that could be a way of saving a life.
right. And that right there has two things to do with what our community tends to be like, because it can be very secretive.
Oh, yeah.
I don't understand it. I don't understand it. Okay, you don't want to go to Cameroon Tribune, I don't know, the Post, and say, ta ta ta, this is what I've got. But in your own family, you're not saying.
No.
Because if you don't say, this is what happens. We go to the doctor's office and they ask us to fill out that form now. Do you have any of this in the family? You are there checking no, no, no.
And you don't know.
You don't know.
You don't
I
know.
understand us not knowing for the grandparents ahead of us. I have no clue what my great grand for me, what happened there.
Yeah.
But now with our modern times and everything, we should note it, we should tell it and pass it down. This is what happened.
Yeah,
So
we
that
should know what our parents are sick of. We should know what they died of.
correct.
We should know what our brothers and sisters were sick of, what they died of, our cousins, stuff like that. Because there are a lot of things that we can prevent just by having that
Know
information.
if we know.
Yeah.
And village people is not part of the what you can put as what oh my lordy. Leader is village people got him. I
Yeah.
mean, okay. Let us understand the village, even if the village people got them, okay, then the village people gave them the so cancer. So okay, the cancer was the thing, even if you believe that it was caused by village people.
Yeah.
And just because these things are just almost infuriating to me. You don't say, and you think it's just you, but it's affecting the rest of your family because they're not saying that. The doctor doesn't know what to look. The doctor himself is doing a guessing game on the thing.
Yeah. It's like
You know,
flying a plane blind, like flying
right.
blind. You don't
Not
have
fair.
that information. Imagine somebody who has a parent who had a heart attack and they don't know. And they always come to the office and their blood pressure is not necessarily very high. But you may want to tell somebody, oh, by the way, I had a dad who passed away from a heart attack. So that they can look into it and make sure that it doesn't happen. You never know, but
Never know.
you have to
Say,
try.
for me, there's two places you just don't lie. Don't lie to your pastor. You didn't tell him clear and clear what happened there. Then don't lie to your doctor.
Yeah.
Where you put in the age de combat thing that you had there.
Yeah.
You can't come and tell your doctor now that you are 18 if you are 50.
Right. So the treatment changes. The treatment changes. It changes.
Totally. And I'm saying that we are giggling, but we both know people that's the case. I mean, even if you do that, you've done that for clerical reasons, academic reasons, career reasons. You get in there, you tell the honest truth, because then he knows what he's working with and knows how to diagnose. I cannot say it enough, but you have, trust me, you have helped. The people who need to hear this, people who did not know anything about it, people who don't know how to anticipate it. You're talking about the bleeding, they're spotting. It's what we call it sometimes, even if it's not a profuse bleeding.
Yeah.
You've gone past menopause. I would say, honestly, that's what took me to my doctor to say, what's going on here?
Right.
First time, I'm also not the kind, sadly, not the kind who really just jumps at it. I had to wait to see. They said another spotting and go, what is this? For somebody who has past menopause, doesn't have a period, this is not normal. Go and see this is what you're seeing.
We have to be a little proactive. We have to be proactive.
Have to try. Even me, the last cocoa in that thing, tries to be like, that's not a glaring sign.
Yeah.
It can be normal. Go and see. I guess you're better off being the annoying patient who comes for everything.
Yeah.
You sneeze, you go and say, what's this? What's going on? What's up with this sneeze? Than to not be the person who excuses everything. Surely it's stress. Surely it's this. Go, let them tell you that's what
stress. Yes.
to worry as opposed to.
It's like we used to say back in the day, prevention is better than cure.
It really is not a cliche.
Nothing.
It really is.
You can't beat that. It's always better to prevent it.
Anything else you'd want to add? I mean, I have heard an earful. Each time I talk to you, even with a little bit that I know, I hear one more thing. For me, the takeaway here is really as the things that you've said already, the symptoms that you see, your body, it's not feeling right. It's not to really just self-medicate, because that's how some of us just do. Rob some small to be sick, just do something and go to bed and let it go. You have a busy day, a busy life. So I cannot afford to.
it's important that you should have a relationship with your physician. To have a good relationship with your physician, because it would save you in the long run, and it would prevent you from having little problems here and there, and they'll be able to talk to you honestly and sans embâche, as they say in French, you know.
Tell it as it is, and then
Yeah,
leave
yes, it is, and then
positions. Yes, don't sugarcoat it.
yes.
No matter how, yeah, they will deliver it to you gently, but this is what you're looking at. They won't go through the percentages. This is what happens, but they give you the options. In the end, it's your choice, but they really,
You have an opportunity to know exactly what's going on, and be proactive. Be proactive. React to anything that you see that is abnormal. React to it, and be courageous. Just be courageous. You have a good healthcare system here. It's robust, it's versatile, and they can provide you things that you never imagined that they could provide you with. And there's no point for you to sit at home and suffer with problems that can be easily taken care of.
Solvable.
Yes,
I will tell you, because you are on the doctor end, we are on the patient end. Sometimes you just don't want to hear it. Do you know that it may sound funny, but that it is the thing. You just say, hey, I don't want to know, I don't want to be told that. As if you're not told it, it will take.
It's going to go away. It's not going to go away.
And it is funny, because even I sat here and said, and I'm supposed to have a basic education. But even I sat here and waited and said, what if I go and they tell me this? But then what if you don't go and they don't tell you what's going to happen? So I finally drove myself there, and that's what he said. And he said this thing. I'm like, if you come back and sit down here now and not go follow up with the thing, how will that change anything? Instead, go and see. They said, take everything out. I said, I'm volunteering, turn myself in and take the whole 9 yards out. At least that way, there's a limit to what else can possibly happen.
Yeah.
After that.
And you have to understand that the treatments are not as bad as you think these days. 20 years ago, everybody had a big cut. For a hysterectomy, for example, it was a big cut. Some of them was even worse because they were worse because you had to go vertically. And so even aesthetically, it wasn't the most pleasing. But these days, we do these things robotically. You know, you go home the same day.
I got in there early in the morning by, I don't know, that
by 1 o'clock, you're home.
I was home. Yeah. Groggy, but home.
Yes. So
and just very little things, that's the term for it, little cuts, which the children here were even helping. They made fun out of it. Became a little expedition here. Let's go look at Bobby's cuts. And putting the band-aids there and stuff, and then
it's easy thing. I think we are also scared about that. I mean, I'll say I've seen people who refuse surgery. You wouldn't believe if I told you what's today. Today is Saturday. On Thursday night, I had a patient who refused to have a C-section. And this is not a first C-section, this is like a third C-section. But she wouldn't want anybody to touch her, to put an epidural in her back, and she didn't want to go to sleep. It took us about 5 hours to convince her.
She wants to stay awake and watch it, or what?
I have no idea.
Sorry, we will laugh.
So I can understand why people will be scared to have surgery. She eventually had it because there's no way out. She has to have a
C-section. She has to have that baby.
Yeah. So she eventually agreed to it, but it took us 5 hours to convince her. 5 hours. And this is something that she knew already from the beginning, that she was going to have a C-section. She knew from the time she got pregnant. But it happened. When it comes to gynecologic surgeries, there are very many minimally invasive ways of doing these things these days. You wouldn't even know what happened, and you'll be home the same day, happy, without pain, and more importantly, relieved that you have been taken care of.
And that's why I'm saying this and concurring with you, because this for me is recent. This is fact. Home, and then now not having to bother about anything. You just start to the walk around a little bit. They tell you from the same day, start to walk around a little bit. You just gain your strength back bit by bit. and you've done what needed to be done. So ladies, it's a ladies' thing. Do what the good doctor says to do. Men, you are the husbands, you are the brothers, you are the uncles. Encourage us, because sometimes you may be surprised at what happens. We all come from African backgrounds again. Somebody is there and says, it's 6 children we need to have. You only have had 2.
Oh yeah, that's
and then the two happen to be girls.
yeah. So
Where's the job here?
You're the boy, yes.
You want to put it out? No. So it's, even I'm saying it's a women's thing. Men, you help. You are part of the issue.
Right.
If you have that kind of attitude, we are less likely to want to say to do what we need to do, what the doctor recommends we should do. If you are there saying, threatening us with, okay, I'm going to marry 3 other wives because I need my job here. Then we are saying, okay, no, let's keep going and see how far we can go with this thing. So it's a thing, an appeal, not for just the women. And I would, of course, throw in there, if somebody is saying that to you, you're better off alive with the 2 girls than to be.
Exactly. I'm looking for a boy that's not coming.
Correct. Thank you so much. We're not going to make this one get to the, I think we hit a marathon the other time. I think we went for close to 2 hours.
Yes. But I'm always available to you when you need it.
I will, trust me, I'll be coming right back with the other things for us to talk and talk and talk. Each time this happens, somebody says, I listened. I went and got my, I'm telling you this for a fact. It's as if somebody's going to listen to this one who did not listen to the last one, or it's going to listen this time, and it's now that it will really click.
Yeah.
So our job is to keep talking. I don't know, I'm not the expert, so I go get the expert. And trust me, he just came out of work. He worked this whole morning, came and sat down here to do this. He was actually dabbing the perspiration off his face before we started to do this. So I thank you. I thank you for doing this for us. It saves lives. It helps.
You're most welcome. You're most welcome.
All right, then we'll go ahead and close this off, and I'll see you next time.
Okay, thank you very much. And I'm always available to you. And if anyone has questions, they can always go to Sister Egbe to reach me, and I'll be glad to answer any questions you have.
You see how he has suddenly behaved himself? At the beginning, he said Egbe. I was going to say, you don't ask me.
I'm sorry.
No, that was because I actually said, this is Egbe B1 Munjimbo coming to you. So you said, thank you for having me, Egbe. I'm like, wait, let the show end. Let me deal with him. But now you ended up, you just redeemed yourself, so you get to have the rest of your Saturday nice and free.
I appreciate it.